Welcome back to The Explainer. Today, we're diving straight into some of the most heavily audited non-face-to-face CPT guidelines out there. We're talking telephone E&M rules and the absolutely strict guardrails around outpatient INR monitoring. If you want to protect your legitimate revenue and dodge those painful claims denials, you literally have to know these rules like the back of your hand. So let's get right into it. Okay, quick look at our agenda for today. We're going to hit telephone EM basics, call duration tiers, those tricky exclusion rules, outpatient INR monitoring, and we'll wrap things up with the biggest compliance red flags. Starting off with Section 1, Telephone EM Basics. Let's look at the actual scope and requirements. So telephone EM services, which are your CPT codes 99441 through 99443, are specifically for non-face-to-face encounters, and they have to happen via real-time, audio-only telephone communication. The big catch here? The call has to be conducted by a physician or a qualified healthcare professional, a QHP, and it absolutely must involve active clinical decision-making. You cannot just slap these codes on a brief call for scheduling an appointment or confirming a basic prescription refill. That's purely administrative. And here is a literal, non-negotiable rule, guys. Telephone EM requires an established patient relationship, period. If a brand new patient calls the clinic looking for advice, and your provider spends 15 minutes evaluating them over the phone, well, these specific codes are entirely off the table. No exceptions. All right, moving on to Section 2, Call Duration Coding Tiers. For these codes, your selection is driven 100% by cumulative medical discussion time. It's pretty straightforward. 5 to 10 minutes of actual medical discussion gets you a 99441. 11 to 20 minutes lands you a 99442, and 21 to 30 minutes hits the 99443. Notice anything missing? Yep, the clock for billing doesn't even start until you hit that crucial 5-minute mark. Now, you really need to pay attention to the provider type here. While our target codes today, 99441 through 99443, are strictly for physicians and QHPs, your clinical staff, like registered nurses, actually have their own specific set of codes for this. That's 98966 through 98968. Mixing up who made the call is an instant, guaranteed pathway to a claim denial. Up next is Section 3, Strict Bundling Exclusion Rules. This is where folks often get tripped up. Okay, there are two massive guardrails you basically need to memorize. First up is the 7-day look-back rule. You are strictly forbidden from billing a telephone EM if that call stems from a related EM service provided within the previous 7 days. The second one is the 24-hour exclusion. If the phone call leads to an in-person visit or a procedure within the next 24 hours, or even the very next available appointment, you absolutely cannot bill the telephone code. Let's make this real for a second. Picture this scenario, because honestly, it happens in clinics every single day. A patient calls in on a Tuesday afternoon having severe side effects from a new medication. Your physician spends a good 15 minutes on the phone assessing the symptoms, realizes the patient really needs to be seen, and schedules them for an acute office visit first thing Wednesday morning. So, how are you coding that Tuesday call? Well, the answer is you aren't. In this scenario, the telephone time is completely bundled into the Wednesday face-to-face encounter. Since the call led directly to an in-person EM visit within 24 hours, that Tuesday phone call cannot be billed separately. Trying to bill both a 99442 for Tuesday and the office visit for Wednesday is a massive compliance violation. The work done on the phone literally just becomes part of the pre-encounter work for Wednesday's visit. Let's shift gears slightly and dive into Section 4, Outpatient INR Monitor. These codes are specifically for non-face-to-face blood thinner management like warfarin. CPT 93793 is used for the per-event review and interpretation of a new home, office, or lab INR test result, and it actually includes the dosage instructions. Just remember, it's limited to once per day, and you can't bill it on the same date as an office EM visit. Now, for longer-term management, CPT 99363 covers the initial 90 days of outpatient warfarin therapy, but you must have a minimum of 8 INR measurements to use it. And for each subsequent 90-day period, you'd use CPT 99364, which requires a minimum of 3 INR measurements. But just like our telephone rules, INR monitoring has some really strict boundaries. You have to be incredibly careful not to double dip here. The AMA guidelines explicitly ban billing these INR monitoring codes on the same date as prolonged non-face-to-face clinical staff time, which are codes 999358 and 999359. And you also can't report them alongside overlapping online digital EM services, codes 99421 through 99423, if the purpose is exactly the same monitoring. It's all about avoiding duplicate billing for the same clinical oversight. Finally, Section 5. Let's talk about compliance and audit red flags. When you look at common denial root causes, a few things jump right out. Upcoding without the supporting medical decision-making documentation or duplicate EM billing on the exact same encounter are huge red flags. Also, if you've got multiple same specialty providers trying to bill for non-face-to-face time on the very same day, yeah, you're going to get flagged immediately. Now, for telephone E&M specifically, if your provider fails to document the exact total medical discussion time, your claim is going to fail an audit instantly. You absolutely cannot just write "spoke to patient on phone." You need something like "spent 15 minutes in medical discussion regarding medication side effects." Other massive triggers: identical, cloned notes across multiple patients, or repeatedly billing high-level E&M codes like 99214 or 99215 with poorly justified modifier 25s. Your documentation has to tell the unique, specific story of that patient encounter. Always remember this fundamental rule of coding. Your documentation must explicitly justify the time spent and the medical necessity of that non-face-to-face encounter. In the eyes of an auditor, if it's not written down accurately, it simply did not happen. And vague documentation doesn't just lead to lost revenue through downcoding, it opens a door to severe audit risks that can cost a practice a fortune. So take a hard look at your clinical notes this week, because we all know clean documentation equals clean claims. But ask yourself, if an auditor pulled your last 10 telephone EM claims right now, would your documented minutes actually justify the revenue? Or are you leaving a trail of cloned notes and compliance traps? Think about it and make sure your practice is protected. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.